And thank you so much, Dr. Amoozegar, for a very informative and excellent presentation covering the entire span of SIH, and also for all the fantastic work you do for the people who have spontaneous intracranial hypotension. We kind of commonly find that a lot of our patients at the EDS clinic have headaches that they present to us with, and we know the headaches could be multifactorial in nature. And we find it challenging to diagnose it on the basis of clinical characteristics. A lot of our patients have coexistent orthostatic hypotension or postural tachycardia. So their symptoms could be like, we don't know if it is because of the autonomic headaches due to the sympathetic activity, or do they have some form of tension headache, or do they have spontaneous intracranial hypotension? Do you find like are there any specific clinical characteristics of these SIH-related headaches that you look for in patients to differentiate it from other autonomic headaches?
Yeah, that's an excellent question, and actually a difficult one to answer, because we struggle with the same question in Calgary as well often. So I think, if there's prominent features of postural orthostatic tachycardia syndrome, or POTS, like you mentioned, then certainly I think that might be a first consideration, because although we do see symptoms of POTS in patients that do have SIH, it doesn't tend to be quite as prominent as patients that have the actual POTS, themselves, that they have that condition. So typically it would be a milder feature, particularly the tachycardia. But also, I think, we look for a lot of the other features. So if they have other associated symptoms, such as tinnitus, for example, or, if they feel like their hearing is muffled, if they may have other features like nausea, photophobia with their headaches. And that prominent improvement with laying down also tends to be a little bit more classic, again, for SIH versus POTS. But it can be very difficult to differentiate. And I think, if there's question, or if patients kind of are not clear in the way they're presenting, then I think evaluation by a neurologist or headache specialist would be important. So, feel free to certainly refer the patients. But also imaging can be helpful. So, if it's not easy to clinically differentiate these patients, then doing an MRI, with gadolinium might be a helpful first step. But you're right in that there can be a lot of overlap, because these patients can have tension headaches. They can have, headache related to the neck, instability of the structures of the neck, which can also present in some way in an orthostatic manner, because they can be worse when they're upright and better when they lay down. So.
Perfect. Thank you so much. And I think I have a few questions. I'm looking at the chat here, and there's an excellent follow-up question, which I'm going to start with, is if a patient does not show a leak on imaging, but has all the symptoms of the CSF leak, how would you proceed in terms of treatment in Calgary? And is DSM testing and multi-level patching provided in Calgary?
Yes, that's a great question. And again, one we struggle with quite a bit. So in Calgary, if we have a high degree of suspicion clinically that a patient might have SIH, and other diagnoses have been ruled out, and the imaging is negative, we do often proceed with at least a lumbar or blind level epidural blood patch, just to see how the patient will do at first. And if there is positive response, which often there will be in the cases of SIH, then we will go on to do repeated blood patches and potentially try at higher levels if there's no sustained relief. So we will try going up to potentially mid-thoracic, et cetera, just to see whether we can get a little closer, because often we know with SIH, most common locations for CSF leaks to occur are cervicothoracic junction, or within that vicinity. So we do try to get closer to that target as much as possible, even if we don't have that imaging showing us that might be the case. But yes, for sure, if we do have a high degree of suspicion, and we want to continue to investigate, we do sometimes go on to that highest level test of doing the DSM and CT myelogram to try and help us localize that leak. In terms of multi-level, we don't tend to do multiple levels at the same time in Calgary. I know that's done at some centers, especially in the US, but we do one location at a time. However, we are willing to go up higher if a patient doesn't respond necessarily to a lower level blood patch.
Perfect. Thank you so much. And there was another question where a participant asked, is that how, if you could briefly explain how does the dynamics of CSF flow gets altered with these leaks, and what could be a best strategy to kind of get this homeostasis back to the normal?
Yeah, so that's a difficult, that's a difficult area as well. So digital subtraction myelography is actually a newer technique, I think, for us in Canada in general, and even in Calgary, even though we've been doing it for a few years now. Our neuroradiologist, there's one that's got additional expertise in doing them, and over time we've learned a little bit more about kind of what could be the best way of doing it. So what we're finding is that certain leaks will show up if a patient has it done in a prone position, meaning that they're flat on their stomach when they have the DSM done, but that certain types of leaks will actually not show up that way, and a patient will have to go on to get what's called a lateral decubitus DSM, which means that they lay on their side, so either their right or on their left side, depending on maybe where the leak might be more, if it's more a left-sided leak versus a right-sided leak. So over time, we've refined the techniques a little bit more and have learned a little bit more what patients might be better candidates to have the specialized types of lateral decubitus DSMs done. But having said that, we still have some patients that have the typical prone position and then go on to have the lateral decubitus afterwards if we're suspicious enough. But that's the way it's been done, I think, in Toronto and other centers as well, including Cedars, is that they'll often do a prone plus the lateral decubitus positions. And that's really to look typically for fast CSF leaks, so ones that have high flow rates, but also CSF venous fistulas would be the kind of the common ones that we would be looking for.
Thank you so much. And I'm just being cognizant of the time here, yes, but I'm just going to ask you one last question where a participant asked what does actually post blood patch rebound headache helps us understand? Does it help us know that there was a CSF leak that has been fixed, or does it help us know if that there was actually no leak and just the pressure headache is because of the increased volume related pressure change in the CSF?
Yes, that's a good question. So I think symptoms of SIH prior to getting a blood patch, and they develop rebound intracranial hypertension, or RIH, afterwards, we tend to think of that as actually successful treatment because we feel that we've kind of overcome that low pressure or hypotensive type of headache, and now they're actually kind of in that opposite spectrum, being high. But it is possible that in a person who doesn't have SIH, that if they do get a blood patch due to that excessive volume, that they may develop some rebound intracranial hypertension symptoms. So that is possible. So it's not a slam dunk diagnosis in terms of telling us whether the patient did have SIH. So I think really it's looking back to see what the symptoms were prior to receiving the blood patch, and if they fit with SIH, then once the patient has the blood patch, if there's resolution of those symptoms and then the RIH, we think that is then successful treatment.
Perfect. I see there are a lot of questions which patients have asked in the chat group. I would probably encourage the participants to ask those questions during the interactive session, because I just want to be mindful of the time and don't want to delay too much. So thank you so much, Dr. Amoozegar, for the presentation and answering all the questions.
My pleasure. My pleasure.